Hello, ma'am.
Hello?
So I'm Michael to co-host, ma'am. You can share the screen and start the class name.
Yes, sure. I'll start now.
Yes, ma'am.
Yeah, the recording is on. Okay. Hello, everyone. So we are going to discuss respiratory pathology, third topic of respiratory pathology today. This is our 90-day university free final mastery program. We'll be revising all the important topics for rapid revision and all the volatile facts quickly. High-yield topics of all subjects will be covered, and the most expected topics will also be covered. We'll be discussing one long essay question, short essay questions, and also short answer questions. In Auricle, we have recorded classes, live classes, practical sessions, exam modules, and also hard copy books. Foundational classes are focused on flexible learning with expert instructors and also scope for convenient revision. Live classes, we do have in-depth coverage of all concepts, including previous year questions coverage and interactive learning with MCQs, polls, Viva questions, and much more. There is an exam module which covers the complete syllabus in just 20 hours with focus on exam writing skills. There is a one-to-one doubt clearing session as well. Hard copy notes are also available for flexible learning. Question banks are available with 3 levels of expertise such as beginner, expert. Also, they are useful for your NEET PG and FMGE exams. Practical sessions focus on hands-on experience along with expert guidance. These are the subscription plans which are currently available. So in today's lecture, we are going to discuss respiratory pathology. The first and foremost question, this is a long answer question for you, is lung tumors. Lung cancer is the most frequently diagnosed major cancer. You have to remember that lung cancer is the most common cancer in males all over the world. Also, in males, lung cancer is the most common cancer which is associated with increased mortality. However, in females, the most common cancer all over the world is breast cancer. But interestingly, the most common cause of mortality associated with any cancer in females is also lung cancer, because when breast cancer has good amount of screening programs as well as good amount of therapeutic options. This makes breast cancer treatable, whereas lung cancer has a high rate of mortality. This is something which you have to remember. So the pathogenesis of lung cancer include, first and foremost and most important cause of lung cancer is cigarette smoking. Okay, cigarette smoking is the most important risk factor or predisposing factor for lung cancer. All right. So nowadays, the new thing is vaping. Vaping is also a important cause, and vaping is not safe at all. So it is associated with increased risk of lung cancer. And there are second important thing is environmental exposure of toxin. Okay, toxin exposure. Toxins exposure. What are the toxins associated? We have asbestos. Asbestos is also associated with another important cancer which we are going to discuss further. Asbestos is also associated with classic lung carcinoma. And then other toxins such as cadmium, vinyl fluoride, etc. are associated with lung cancer. And genetic mutations. Okay, first is cigarette smoking, environmental toxin exposure, and then genetic mutations. Different types of lung carcinoma are associated with different types of genetic mutations. We have three major varieties: adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. There are more lesser common varieties, but these are the most common varieties. These three varieties are the common varieties of lung carcinoma. So what are the mutations? Adenocarcinoma has a number of mutations here. The most common being EGFR mutation. Okay, and then the second most common one being RAS. Alright, RAS mutation, EGFR mutation, and we do have ALK mutation, ROS mutation, and MET mutations. So these are the common mutations which are associated with adenocarcinoma. In squamous cell carcinoma, we can see TP53 mutations, and in small cell carcinoma, we can see TP53 as well as RB gene mutations. Okay, so this is for our pathogenesis of lung tumors. Okay, now let's go ahead and discuss morphology. Morphology, as we already saw, we have adenocarcinoma, squamous carcinoma, small cell, and large cell carcinoma. So I would like to just broadly classify these into two categories. Lung carcinomas, broadly classify these into small cell carcinoma and large cell carcinoma. Okay, among the large cell carcinomas, we have adenocarcinomas and squamous cell carcinomas. Okay, there are multiple varieties of adenocarcinoma like mucinous carcinoma, minimally invasive, and multiple morphologic variants also like lipidic, micropapillary, except adeno is nothing but a gland forming carcinoma. It looks like a gland. Okay, so this is how adenocarcinoma is. Squamous cell carcinomas are keratinizing and non-keratinizing as well as basaloid. Neuroendocrine tumors are a big category of tumors, part of which is small cell carcinoma. So uncommon types as we saw were large cell adenocarcinoma, sarcomatoid, and other variants. So these are the most common tumors which you have to remember. Now let's go ahead and discuss clinical features. What could be the clinical features? So definitely cigarette smoking, and there is a mass in the lung, so we have cough. And hemoptysis. Hemoptysis is nothing but blood tinged sputum. Okay. And then we have weight loss. Definitely weight loss is a characteristic feature of all types of carcinomas here. And then we have something which is called as paraneoplastic syndromes. Paraneoplastic syndromes are the conditions which are associated with carcinoma. Okay. They arise because of the presence of these tumors, but they would not arise if tumor was not present. So they're associated with this carcinoma. So two most important paraneoplastic syndromes which you have to remember is paraneoplastic Cushing syndrome, which is associated with small cell carcinoma. Small cell carcinoma produces ectopic ACTH. Okay, that is ectopic ACTH production because of small cell carcinoma, because of which ACTH, as we know, ACTH is usually produced in the pituitaries. But if ectopic ACTH production is there, it can lead to increased cortisol production. Whenever increased cortisol production is there, we know the disease which is going to occur is Cushing's syndrome. Okay, so this is small cell carcinoma, and the associated paraneoplastic syndrome with squamous cell carcinoma is going to be hypercalcemia. Why is hypercalcemia occurring? Because there is a peptide PTHRP. What is this PTHRP? Parathormone related peptide. This peptide is being produced by the tumor cells. These are not exactly parathormone, but parathormone related peptide. You know what is the function of parathormone, right? What is the function of parathormone? To increase calcium levels and decrease phosphorus levels. So this is its function of parathormone. Our parathormone related peptide also simulates the same function and increases calcium level, hence hypercalcemia. Okay, so these are the things which you have to remember. First of all, definition, what is lung carcinoma, and then lung tumors are the most common tumors, mortality of lung tumors, then pathogenesis. We have pathogenesis, we discussed, it was cigarette smoking, environmental exposure, genetic mutation, different types of genetic mutations which are present in squamous cell, small cell, and adenocarcinoma. Most common mutation in adenocarcinoma, EGFR mutation, and then morphology, lung, small cell, large cell had adeno as well as squamous, and then different types, okay, and clinical features along with paraneoplastic syndromes. So that is your review of lung tumors. Now moving on to the second question, small cell carcinoma of lung. This we have already discussed. Remember that small cell carcinoma and squamous cell carcinoma, both of these are associated with smoking. And also remember that these are centrally associated tumors. So we have lungs here, and this is the bronchus. So surrounding the bronchus, bronchial area, whenever the tumor is centrally associated, it could be either small cell carcinoma or squamous cell carcinoma. But a peripherally associated tumor can be adenocarcinoma. And also remember, adenocarcinomas are not associated with smoking or rarely associated with smoking. So this small cell carcinoma is associated with smoking. It is a very aggressive tumor, has a rapid growth and has a propensity of metastasis. We saw what were the genetic mutations which were implicated in small cell carcinoma. They were loss of retinoblastoma gene loss and TP53 loss. Why loss? Because these genes are tumor suppressor genes, right? Both these genes are tumor suppressor genes. Because these are tumor suppressor genes, they are lost. If tumor suppressor genes are lost, then it's going to increase the risk of tumor. Okay, so this is small cell carcinoma. Also, you have to remember the paraneoplastic syndromes associated with squamous small cell carcinoma. Most common was ACTH, ectopic ACTH production, which led to Cushing's syndrome. Okay, these are the main things which you have to remember about a small cell carcinoma of lung. Now we'll discuss bronchial carcinoid. Carcinoid is a tumor which arises from neuroendocrine cells. The name itself is a misnomer because OID anywhere means like, right? Carcinoma like. But this is not a carcinoma, this arises from neuroendocrine cells. Neuroendocrine cells are normally present in the bronchial region and sometimes they may undergo hyperplasia. Okay, and then they may form a small tumor-like condition resulting in carcinoid. Okay, bronchial carcinoids can be of two types. Alright. Bronchial carcinoids can be typical carcinoid and atypical carcinoid. Typical carcinoid is nothing but it's a simple low-grade tumor. So this is low-grade tumor where mitosis is also less than 2 per 10 high power field. So why is mitosis important? Mitosis is nothing but the replicative capacity of cell. So the replicative capacity of the cell is less than 2 per 10 high power field. It means it's not much replicative. Okay. Because of that, this tumor is well differentiated tumor. This is a low-grade tumor. And there is no necrosis. Okay, but atypical carcinoid 2 to 10 per 10 high power feet. So this is little bit more replicative tumor and this has necrosis. Okay, this is little bit aggressive compared to typical carcinoid. Okay, what is the important function of this carcinoid? Carcinoids are sometimes hormonally, sometimes they produce certain enzymes. So sometimes carcinoids can produce serotonin. Okay, which the metabolite of which is 5-hydroxytryptamine, which can be found in urine testing. So these are the few important points which you have to remember about carcinoid. How do they look in histopathology? They are nests of small cells. Okay, they are usually arranged in nest-like appearance. So that is how carcinoid looks like. Okay, nest of cells. Usually they have salt and pepper chromatin. What is salt and pepper chromatin? The nucleus is there and nucleus will have many light areas and darkly stained areas admixed together. So that is what salt and pepper chromatin means. Okay, now we are going to look about a few facts about pneumoconiosis. Okay, pneumoconiosis, first of all, we discuss the pathophysiology of pneumoconiosis. Pneumoconiosis is nothing but lung diseases which occur due to exposure of certain environmental substances such as silica, asbestos, coal, okay, sugarcane, cotton dust, and all these things. Okay, so this is what pneumoconiosis is. So why does this occur? First of all, the particle size is very much important. Okay, particle size is very much important. Which particle size will get deposited inside the lung alveoli? We know our lung alveoli is very small, right? So particle size, the critical particle size is 1 to 5 microns. 1 to 5 microns is the critical particle size. If the particle is less than 1 micron, then what is going to happen? Then the particle is going to be phagocytosed by our macrophages and it is going to get excreted through. If the particle is more than 5 microns, what is going to happen? Sometimes it can be cleared by the mucus particles and bronchial dust and it can also be cleared. So 1 to 5 microns is the critical particle size in our pneumoconiosis. Okay, this is something which you have to remember. And then sometimes when these particles stay there, they trigger an inflammatory response and release numerous number of cytokines, okay, which trigger fibrosis. So that is why what happens, most of these pneumoconiosis, you will have fibrosis, interstitial fibrosis. So all pneumoconiosis almost always are associated with interstitial pulmonary fibrosis because of the inflammatory response which usually produces a cytokines which end up in fibrosis. Okay. So this is one pneumoconiosis which we are going to discuss. This is silicosis and this has been asked. Of course, as the name indicates, the pathogenesis is due to inhalation of silica dust particles. Okay. Morphological changes, you can see here, there are a few silica particles. Okay, this black thing, what is this? Is this silica? No, this is nothing but normal carbon particles. It's normally present in the lungs. Okay, but why is this important? Is surrounding the area. You can see here there is normal alveoli. Everything is normal here. But there are a few areas where whirling and bundling is happening. So sometimes around the area, because of inflammatory response, I told you fibrosis can happen. Similarly, fibroblasts can proliferate, collagen can deposit, and fibrous areas can be there. And collagen and in silicosis especially, silicosis is a little bit larger particle. So it goes and gets stuck in the air spaces and sometimes can form larger areas of collagenization in silica. So these things you will remember. And in radiology, very important, eggshell calcification. Why eggshell calcification? In histology, you can see that so many large areas of fibrosis and collagen deposition is there. So these areas are dead and degenerated. Calcium is going to come and accumulate in these areas. That reflects as eggshell calcification in radiology. Okay. Also remember, silica is associated with tuberculosis. So patients with silicosis have increased risk of tuberculosis. Also, in any pneumoconiosis, any lung disease, if the patient is a smoker, the risk of the aggressive disease is going to increase because smokers have decreased mucociliary clearance. Because what happens for general physiology? Let's just go back to general physiology. What happens in smokers? As you remember, our ciliated columnar epithelium, which is present in the bronchial membrane, this is going to convert into squamous epithelium because of chronic smoking. So, which part of the bronchus is essential for mucociliary clearance? Which part of the bronchus? It is this cilia, correct? So, if the cilia is lost and this epithelium is transferred into squamous epithelium, this is going to affect the mucociliary clearance. So if any particle is there, it's not going to go out by mucociliary clearance. So any smoker is going to have excessive symptoms when they're exposed to silica dust or any other materials like silica, coal, asbestos, etc. So smoking is going to increase the risk. Similarly, tuberculosis risk is increased with silicosis. Now, who is going to tell me what is the process? What is this change called? What is the cellular adaptation called? Where this respiratory epithelium changes into squamous epithelium. This is known as metaplasia. Okay, it's a revision of your general pathology. Now the next question is viral pneumonia. So we have a few age groups and community acquired pneumonias. Remember, the most common cause of viral pneumonia is influenza. That is the most common cause of viral pneumonia. So remember, in 2 to 24 months, we have respiratory syncytial virus as the most common cause. And then in 2 to 5 years also, respiratory syncytial virus is there, human metapneumovirus is there, parainfluenza virus is there, but older than 5 years, you have pneumonia. But in adults, the most common cause is influenza virus. In older than 5 years, anyways, they get pneumonia. So what is the morphology of viral pneumonia? What kind of cells will be present in viral pneumonia? When you do a biopsy of this viral pneumonia, what kind of cells will be there? You will see lymphocytes and monocytes mostly. Okay, viral pneumonia, any viral infection, the first kind of cells which will come to the rescue is lymphocytes. In bacterial pneumonia, which kind of cells will be there? In bacterial pneumonia, you will have neutrophils. Okay, so lymphocytic infiltration will be there in viral pneumonia. Now, let's go ahead and discuss pulmonary hypertension. Pulmonary hypertension is nothing but pulmonary hypertension can be defined as a pressure which is more than 25 mHg at rest. The pulmonary artery pressure more than 25 at rest is pulmonary hypertension. What are the causes of pulmonary hypertension? The causes of pulmonary hypertension can be constriction of smaller pulmonary vessels, smaller pulmonary vessel constriction, or the causes can be heart failure because of heart, or the cause can be because of a lung disease, okay, or it can be because of thrombosis in the pulmonary artery leading to increased pressure, okay. Thrombosis we have discussed. Or lastly, idiopathic. Lastly, pulmonary hypertension can be idiopathic. So why idiopathic hypertension? This is a very least common cause. Most common cause of pulmonary hypertension is because of lung diseases, COPD, emphysema. Okay, they can actually put back pressure and increase the pulmonary artery pressure and result in pulmonary hypertension, which will result in carpal nail. And when carpal nail occurs, then it will eventually lead to lung failure. This is the sequel of the things. Why does idiopathic pulmonary hypertension occur? What is the cause of idiopathic pulmonary hypertension? So, there is a genetic mutation BMPR2 which is implicated in the cause of idiopathic pulmonary hypertension. What BMPR2 does it? It produces excessive TGF beta. Okay, TGF beta is that one cytokine which is implicated in the formation of fibrosis. So now what will happen is the TGF beta increases formation of fibrosis of small pulmonary arteries. So if the small pulmonary vessels get fibrosed, their lumen is getting blocked, resulting in increased pressure, right? So resulting in pulmonary hypertension. So what is being given as a treatment for pulmonary hypertension? You have to, since the lumen is being blocked, you have to dilate the vessels. So vasodilation. Okay, vasodilation is the treatment for this pulmonary hypertension and especially idiopathic pulmonary hypertension. Okay. Now, this is another question. We can see they have asked non-small cell carcinoma. So small cell we had already discussed. Non-small cell we had two. Adenocarcinoma and squamous cell carcinoma. So we'll have to discuss the subtypes of adenocarcinoma. We've already discussed that. And then we can discuss the genetic mutations. I'll just review it once for you. There are 5 most important genetic mutations in adenocarcinoma, EGFR being the most common. And then we have RAS, okay. And then we have ROS, ALK, and MET. Squamous cell carcinoma also had TP53 mutations, okay. So these were the mutations. Now we can discuss the morphology. Adeno, as the name says, this tumor will have gland formation, okay. Gland forming tumor is adenocarcinoma. Okay, squamous cell carcinoma, the morphology, you will have squamous pearls in well differentiated squamous cell carcinomas, and the squamous cells are going to be large, polygonal. Okay, as this is a carcinoma, you will have nuclear atypia. You are going to have mitosis. You can also have necrosis. Okay, these are the features which you have to mention. Squamous pearls you will have, and then Squamoid cells will also always be polygonal with eosinophilic cytoplasm and darkly stained nucleus. Okay. Okay. Now this is a type of pneumoconiosis only, which is known as bagasosis. Bagasosis is nothing but an occupational lung disease caused by inhalation of sugarcane dust. So as I told, you just have to know that this bagasosis is just a fancy name for inhalation of sugarcane dust. Okay, this is a type of pneumoconiosis. Everything else is going to be similar for pneumoconiosis. Whenever there is inhalation of dust, I told you that critical particle is going to be 1 to 5. Critical particles are going to be 1 to 5 microns, correct? So 1 to 5 microns, they're going to be in the alveoli. 1 to 5 micron particle cannot be cleared by mucociliary clearance. They cannot be cleared by phagocytosis, correct? So what will happen? They're going to stay inside the alveoli. They're going to trigger inflammatory response. They're going to keep on producing cytokines unless there is fibrosis, resulting in pulmonary fibrosis. So what will happen after pulmonary fibrosis? After pulmonary fibrosis, this can ultimately lead to pulmonary hypertension. Okay, pulmonary hypertension can eventually lead to pulmonary and then failure of lung. So this could be the sequelae of things. Remember, this is inhalation of sugarcane dust, and there's something else called biccinosis, which is inhalation of cotton dust. These are just names, but the pathophysiology, everything is going to be almost similar in all cases of pneumoconiosis. Kaplan syndrome, another fancy name. Kaplan syndrome is nothing but the combination of pneumoconiosis along with rheumatoid arthritis. Okay, remember arthritis occurs in joints, right? Kneecap cartilage. So knee has something called kneecap. So remember joint, Kaplan syndrome, arthritis. I mean, just a way to remember. So this is what Kaplan syndrome is, the combination of pneumoconiosis as well as rheumatoid arthritis. Okay. So neuroendocrine tumors of the lung. We have already discussed typical and atypical carcinoids. Apart from this, other neuroendocrine tumors are also there. Okay. I'll just review typical and atypical carcinoids for you. We know that they are nest-like tumors. We know that neuroendocrine cells are already present in our lung and they may undergo neuroendocrine hyperplasia and they can also cause carcinoids. Carcinoids can be typical and atypical. Typical carcinoids are less aggressive. They had less than 2 mitosis per 10 hyperfield. They had no necrosis. Atypical carcinoids had 2 to 10 mitosis per 10 hyperfield. Okay, but they had necrosis. Now we have large cell neuroendocrine tumor, and small cell neuroendocrine tumor. Okay, these are all tumors which are even more aggressive than normal carcinoids. So our large cell neuroendocrine tumor will have something about more than 10 mitosis. Okay, small cell neuroendocrine tumor is even more aggressive. So it can have up to 10 to 30 mitosis also, and both of these will have necrosis. Okay, so these are all aggressive tumors. The small cell neuroendocrine tumor can be small cell carcinoma also, which is extremely aggressive. So remember the morphology, nests of small round cells. They can metastasize also. Okay. and they are produced from normal neuroendocrine cells which are present, which can undergo hyperplasia. Okay. So now malignant mesothelioma. As I already said, asbestos exposure. We saw asbestos exposure which was associated with lung carcinoma, normal carcinoma. Remember the most common tumor. You may be asked these questions to just confuse you. Asbestos can be associated with malignant mesothelioma and also lung carcinoma. So if you're given an MCQ and you were asked both, always select both. Okay, and also most commonly when asbestos is exposed, you will get lung carcinoma when compared to mesothelioma. Okay, so these are some facts about asbestos exposure. So we have mesothelioma can be histologically, they can be epithelioid and sarcomatoid. These are again just names. Epithelioid is looking like an epithelial cell. So the cell is going to be round or polygonal in shape with central nucleus. Sarcomatoid is looking like a sarcomatous cell. So long spindle cells. Since this is mesothelioma, it is a malignant tumor. We are going to have mitosis. We can have necrosis and atypia. These things can be there in any malignant tumor. Now I want to tell you a few IHC. What is IHC? IHC is immunohistochemistry. Immunohistochemistry, why is it used? Because certain tumor cells express certain specific proteins. And if we do a particular stain against that protein, we can identify, okay, this is this tumor cell for sure. And we can go ahead and treat for that tumor. So that is the reason for doing an IHC. There are two important IHC specific markers which can be found in mesothelioma. One is calretinine and the other one is WT1. Okay, WT1 can be found in other tumors also, but it is good for mesothelioma. Calretinine and WT1. Sometimes we have to distinguish between pulmonary adenocarcinoma and mesothelioma. Even though mesothelioma usually occurs in the pleura, adenocarcinoma can also go ahead and metastasize to the pleura. So you have to differentiate between malignant mesothelioma and adenocarcinoma. For that, these markers can be effective to find out because the treatment is totally different between these two tumors. Okay. Now let's just try to solve a few MCQs regarding this topic. We have discussed all these questions, but just let's try to solve a few MCQs. Which genetic mutation is most frequently associated with lung adenocarcinoma? This is a very easy question. I've told you all these, even though KRAS is associated with lung adenocarcinoma, TP53 is associated with squamous and small cell, right? EGFR is also associated with lung adenocarcinoma. BRAF is also associated, but the most common one here is EGFR. Okay. Which of the following paraneoplastic syndromes is most commonly associated with squamous cell carcinoma of the lung? This we have already discussed. SIADH, Cushing syndrome, this Lambert-Eaton myasthenic syndrome, all these three syndromes are associated with lung carcinoma, but these are all associated with small cell lung carcinoma. Cushing syndrome we had discussed already, right? SIADH is associated with small cell lung carcinoma. Lambert-Eaton is associated with small cell lung carcinoma. But the only thing which is associated with squamous cell carcinoma is hypercalcemia. We also discussed why. Because of PTH related peptide secretion, which increases calcium levels by acting like parathormone. Okay, now bagasosis is caused by inhalation of? This is very easy. Just discuss now. Sugarcane. What is cotton dust? It's called as carcinosis. Okay. Coal dust, anthracosis. Okay, so these are the important things. The most common cause of viral pneumonia in adults is this also we had discussed, influenza virus. And if they ask the most common cause of pneumonia in children, it is respiratory syncytial virus. Okay, so that's all for today's class. Thanks for watching.